Good afternoon.
Good afternoon.
It's a great pleasure to be here to all of you distinguished servicemen, veterans, and women, and to our Secretary Hall. We thank you for this opportunity to speak with you this afternoon, and I needed Patrick to validate all of the information that I'm going to give you because he's the one with proven experience in this work. So thank you for allowing us to speak with you this afternoon. We are going to talk for as fast as we can because we want to allow time for your questions later about Medicaid managed care. And we thank Gina for giving you information about how a person qualifies for Medicaid. We're going to tell you a little bit about how the program is going through some major changes. We're in the process of designing those changes, and we want to make sure that you're informed about what this shift means for the Medicaid program and for veterans who may access it. So in 2015, the General Assembly passed some legislation that mandated that the state of North Carolina move our program from a fee-for-service program to a managed care program. And what that means is in a fee-for-service system, we pay for services at the individual unit level. And in that system, it can incentivize providers to bill a lot of services because it pays for each discrete service and in some ways can reward quantity rather than quality. In a managed care system, you have an experienced managed care company who is responsible for making sure that we just don't pay for services for people, but that we are paying for people to get better. And that is the purpose of this transition to a managed care program. It is the most significant change to Medicaid since it began 40 years ago. So this is a major shift for us for that reason. It is also significant because we will move 1.6 of our 2.1 Medicaid beneficiaries into this managed care system. Million. What did I say? 2.1?
Well,
nothing.
Yeah,
2.1 million recipients. And of that total Medicaid recipients, 1.6 million of them will go into the Medicaid managed care program. We are using, or a partner in this program, are prepaid health plans. They're managed care organizations who will be responsible for the oversight of the Medicaid managed care delivery system. We're going to roll out managed care in North Carolina on a regional basis, and we want to make sure that we are taking assertive, thoughtful steps in how we implement managed care, and so we did not want to flip the switch and implement managed care across the entire state at the same time. And Patrick is going to describe the regions for you and give you a time frame for how that transition will occur. We're really excited about the fact that this change in Medicaid is going to enable us to pay not only for traditional medical services, but we will also be able to pay for non-traditional medical services, what we're referring to as unmet social needs. So we can use the Medicaid program to reimburse for transportation, for people to access food, for people to access housing, and for people to address interpersonal violence. Because data demonstrates that 80% of a person's health outcome is impacted by non-medical drivers of health. And so we're very excited about this opportunity. I will also mention that we recognize that this is a complex shift, and there will be multiple prepaid health plans that individuals will have to choose from. And so we have selected an enrollment broker who is independent from the managed care companies who will provide choice counseling to individuals, help them understand their options, and help them navigate the process of choosing a managed care company. What is our vision for managed care? The Secretary of Health and Human Services, Mandy Cohen, envisions that we're going to improve health by providing whole person care. For anyone who's familiar with our behavioral health system now, currently, if you have physical health needs, those needs are met through the fee-for-service system that I talked about earlier. But if you have behavioral health needs and you're in Medicaid, then your services are managed through the local management entity or MCOs, LME MCOs. And that's a bifurcated system where one part of the system treats a person's physical health needs and another part of the system treats their behavioral health needs. With managed care, we're going to focus on the whole person and having physicians and managed care companies who are responsible for all of the care that that person receives. We want to make sure that that care is well coordinated, that we're focusing on innovation. Remember those unmet social needs that we'll be able to address? We are doing that by asking partners to identify evidence-based interventions for people. So we're focusing on innovations, and as I mentioned, we're going to focus on medical and non-medical drivers of care. Patrick's going to talk about who our partners are.
Good afternoon. I first want to give a shout out to all the soldiers, sailors, airmen, Marine, and Coast Guardsmen. I'm proud to have served with many of them, and it's nice to be back and talking to some of them. So you may have heard about this big change to managed care that Deborah's been talking about. It's been all over the news, but in case you haven't, we announced the award to these PHP, the contract winners on February 4th. And so here's a list of the 4 statewide contracts: AmeriHealth, Caritas, Blue Cross Blue Shield, United Healthcare, and WellCare. And then we awarded a regional contract to 2 regions to Carolina Complete. And so if you go to the next slide, what that means is those first 4 got statewide regions in regions 1 through 6, and then Carolina Complete Health, CCH, got the award for regions
1, 3, 5, and
1,
6.
3, 5, and 6.
Yep.
I know it's
It.
complicated. The rollout phase is listed in the blue box there. We're targeting our first rollout for managed care, and we're doing this very, very conscientiously on purpose. We're not going to try to do the whole state. We're going to try to do it in a phased approach. So notice, phase 1 is November of 2019, just in regions 2 and 4. And if you notice, Region 4, obviously, with Wake County specifically, much larger, more urban, surrounded by lots of rural, and then Region 2, not that there's urban centers in there, but more rural. That's going to be our first 2 regions. Then in February of 2020, we're going to roll out the rest of those regions, regions 1, 3, 5, and 6 in February of 2020. So here's a timeline for everybody that shows our Medicaid transformation. February of 2019, we've already started member educational materials that are being mailed out to specific members that we've identified. The star there for June of 2019, we're calling a soft launch. Our call center we're going to open, and we're going to start sending out welcome packages. And that's coming up rapidly. In the summer, it says PHPs are contracting with providers and meeting their network adequacy. I know that those PHPs are already very busy contracting with providers. You know, they're also partnered with us now, and they need to get those providers all signed up and all those contracts signed, sealed, and delivered. July and through September of 2019 is when our open enrollment period is going to begin for beneficiaries, and then there's the big star, November of 2019. That's our first phase 1 launch in regions 2 and 4. Notice in November of 2019 we'll start that second phase 2 in open enrollment, heading towards that February of 2020 for those remaining 4 regions.
So I mentioned that only 1.6 million of the 2.1 Medicaid beneficiaries are going into managed care. This slide just provides some detail for you about who those people are that must go into managed care. Initially, the initial rollout will impact a lot of pregnant women and children. Gina mentioned earlier, there are some people who are excluded. She talked about individuals who are dually eligible for Medicaid and Medicare. Those individuals will be excluded. There's a third category of individuals that are impacted, and those are individuals who are considered exempt, which means they can choose to participate in managed care or they can remain in the fee-for-service program. And those individuals are members of the federally recognized tribe, the Eastern Band of Cherokee Indians, and then individuals who are eligible for tailored plans. And I did not mention earlier that our model requires us to have fully integrated care, but we will have two types of plans. There are standard plans who will provide physical, behavioral health care and pharmacy for people, but in the standard plans, individuals who have behavioral health needs, their conditions will be mild to moderate conditions. If you have a serious mental illness, an intellectual or developmental disability, you will get your services in a tailored plan. The tailored plans are much like the standard plans, but they will be operated by the local management entities that we have today. Local management entities, LME, MCOs, for those of you who are familiar with that system. And those individuals who are eligible for the tailored plans the tailored plans will begin in 2021. Those individuals can choose to remain in the fee-for-service system until that tailored plan is available in July 2021. This is a list of those individuals who are excluded. I think that you all will have access to this PowerPoint, so I won't review all of them, but just note, as I mentioned earlier, that people who are dually eligible are considered excluded, which means they cannot participate in managed care. They must remain in the fee-for-service system. There are some services that people will be able to access in the fee-for-service system, and that includes dental services as well as a number of other services. Those for children through the local school system, and for very young children through the Children's Developmental Service agencies. And you'll see a few other services listed there. This is a high-level overview of the process for a person being determined eligible. And how they get into managed care. So once a person applies for Medicaid, they can specify their choice for a prepaid health plan during the application process. If they know, they can make that choice, and if they are determined eligible, then they would be automatically assigned to that prepaid health plan. DSS is going to retain responsibility for determining eligibility. That will not change. Nothing about Medicaid eligibility will change with this managed care implementation. If you qualify for Medicaid prior to November 2019, you will continue to qualify for Medicaid. If a person selects a prepaid health plan, they will be assigned to that prepaid health plan. The prepaid health plan will get their demographic information from NC FAST, which Gina mentioned earlier. And then the prepaid health plan will send written information to that individual. They'll send their ID card, they'll send their member handbook, and information about how to choose their primary care physician if they have not selected one. If a person does not know what choice they want to make, if they do not choose a prepaid health plan, we will assign them a prepaid health plan. During the initial transition, the open enrollment period that Patrick mentioned between July and September 2019, when that open enrollment period ends, if a person has not selected a prepaid health plan, they've got choice counseling, or maybe they just weren't ready, we will assign a prepaid health plan to them. And we have certain rules that define who we will assign. Which prepaid health plan has their doctor in their network is going to be the most important thing. Are there other family members who are enrolled with a certain plan? What area of the state does the person live in? So we'll follow a series of rules to determine which is the best plan. But let's say we get it wrong and we put somebody in a prepaid health plan that they're not satisfied with. A person will have 90 days after that assignment, after we go live with managed care, to make a change. And then they can change annually. And if you have certain needs, or the prepaid health plan can address those needs, then you can change at other times. And you can appeal your decision. If we deny your choice to change, the person will have appeal rights to that decision.
So it all sounds complicated. It is. But our goal, come November 1st, when we roll out this change, and then February of next year, we tried to keep it basic, and these are kind of what we are going to consider a success, is that if a person with a scheduled appointment will be seen by their provider, that a person's prescription will be filled by a pharmacist, that calls made to call centers are answered promptly, individuals know their chosen or assigned PHP. I know, and this all sounds simple, but there's a lot going on behind that curtain for this to all happen successfully. But this is what we're committing to. Individuals have timely access to information and are directed to the right resource. A provider enrolled in Medicaid prior to November 1st will still be enrolled. Providers are going to be paid for care delivered to members, and PHPs have sufficient networks to ensure member choice. So the key to all those points are our goals at NC Medicaid and the Department of Health and Human Services is we want to take care of our beneficiaries first, and we want to take care of our providers. And if we do that, then we're going to be very happy.
Absolutely. And we expect the prepaid health plans to do that as well.
Yes,
We're
yes.
going to hold them accountable for doing that. This is a very, our motives and our goal is to make sure that people are getting better, that we are buying health, and we expect the plans to hold up to that standard and to meet those expectations. We're going to jump into Medicaid expansion and what that might mean for veterans, and Patrick's going to start with that.
So once again, expansion is out there. It's in the news, and it's a very high visibility, both nationally and obviously here in the state of North Carolina. So I just wanted to talk a few points about our Medicaid and expansion. Obviously, there's a lot of North Carolinians out there that don't qualify for Medicaid. They just don't earn enough. So if we expand Medicaid eligibility, it would give more than 500,000, 500,000 North Carolinians access to affordable quality health insurance. Expansion makes Medicaid available to all adults under 65 with an income below 138% of the federal poverty level. Okay, next slide. Here's a good map. I like charts and maps. There's in the blue are states that have expanded to Medicaid. Notice North Carolina is yellow, so that's why it's on the docket and being discussed.
I just want to say that as members of the Department of Health and Human Services, for us, the expansion of Medicaid is not a political decision. It's a healthcare decision, because we know that hundreds of thousands of individuals will get access to medical care. And that is the reason that we wanted to talk about this today, because expansion of Medicaid will lower health care costs. And in states where you've seen Medicaid expansion occur, we've seen a closure of the coverage gap, and individual market premiums go down on average 7% lower than for states who have not expanded Medicaid. So we think it makes good healthcare sense to us, and it makes good financial sense. Our state, along with many other states in the nation, are facing a huge opiate crisis. And by expanding Medicaid, a number of individuals who are combating this disease will be able to access affordable health care. And you will see here that there's an indication that in Dayton, Ohio, they saw a 54% decrease in opiate overdose deaths after the state closed the coverage gap. Patrick's going to talk a little bit about what this means specifically for North Carolina veterans.
So North Carolina has one of the highest rates of uninsured veterans in the nation. Over 7% of our North Carolina veterans lack any type of health coverage. The uninsured rates among the veterans and their family members have declined faster in states that have expanded Medicaid compared to those states that have not. Next. So obviously, as Deborah said, for us, it's all about health care, and veterans need Medicaid. Not all veterans qualify to receive health insurance through the Department of Veterans Affairs. That's kind of what we've been talking about. Eligibility, as Gina mentioned, depends on a variety of factors, minimum service requirements, disability, discharge, and 16% of service members separated for misconduct during those fiscal years of 2011 through 15 had been diagnosed with post-traumatic stress disorder or a traumatic brain injury. And notice, that's from 2011 to 15. I don't have those numbers yet, but I bet you from 2015 to present, that percentage has gone up from a PTSD standpoint. Well, and there's a bullet that I didn't have on here, but which I thought was very interesting. According to the VA, in 2017, only 46% of North Carolina veterans were enrolled in the VA. So 46% were enrolled. Of those 46%, only 32% were reported as a patient treated in the VA health system. So I thought those numbers to me were very interesting. In other words, there's a lot of veterans out there that are not getting health care. I think we all know that veterans have an increased risk. Many veterans suffer from all these very unique, sometimes serious and complicated health issues as a result of serving their country. Low-income veterans are more likely to be more sick, have PTSD, substance abuse, mental health disorders compared to higher income veterans. And so expansion is going to help veterans access those critical services that would improve their overall health and help them achieve financial stability. And we were talking about veterans' families. See, veterans' family members rarely qualify for VA assistance. So this is something where expansion can help out. Expanding Medicare would benefit not just veterans, but their family members as well.
So what does this mean in terms of financial impact on North Carolina? The federal legislation requires that the federal government will pay 90% of the cost of coverage for those individuals who fall in the coverage gap. And it talks about how long they will do that. And so what that means for North Carolina is that 90% of the cost of expansion will be covered by the federal government. The remaining 10% we are proposing would be paid for by hospital systems, because hospitals treat a lot of people who are uninsured. And so if those uninsured individuals can have access to Medicaid, we believe the benefits to the hospital system will enable them to help pay for the cost of expansion. We appreciate your time today. We recognize we've gone a little bit over, but thank you. And it's been a pleasure to talk to you.